Muy buenos días y muy bienvenidos
Good
al segundo
morning. Welcome to this seminar on good practices for non-communicable diseases. I'm Silviana Luciani, head of the program of non-communicable diseases from PAHO here in Washington, D.C., in the headquarters. It's a pleasure, an honor for me to be here with you. Today, we're going to focus on the effective experiences in the management of non-communicable diseases, such as diabetes, hypertension, cancer, with an approach on primary healthcare. This session is available in 3 languages. We have simultaneous interpretation in English, Portuguese, and Spanish, so you can choose the language you prefer. You have a bottom interpretation, and we want you to participate, to ask any questions, to share any comments. You can use the chat box to do so, or the questions bottom. To launch this session, today we're going to facilitate the exchange of experiences, the strategies that help manage the non-communicable diseases. We have Dr. Hennis with us. Thank you, Silvana. Good morning, everybody. Welcome to this second seminar that is part of the series Good Practices for Non-Communicable Diseases, organized by the Pan American Health Organization. As you all know, non-communicable diseases such as hypertension, diabetes, cancer, and respiratory or chronic respiratory diseases represent currently one of the highest rates of morbidity in the Americas. They have a great impact on more than 240 million people, with a high impact also on the quality of life. However, there are still many important challenges. In the hypertension domain, less than 40% diagnoses that lead to the management of the disease. 13% of adults have this disease. More than 40 million people do not have access to the treatment they need. The asthma, we are talking of a quarter of the people that have asthma have control over the disease. So this represents a risk for their lives. Cancer affects more than 4 million people every single year. This reflects inequalities in the access to services and coverage, and cost-effective interventions such as vaccination and screening. This data shows how urgent it is to increase the quality of diagnosis, treatment, control from primary healthcare. We need to guarantee the access to medicine, technologies, and quality services. Millions of people in our countries live with hypertension without knowing it. They receive a diagnosis that is not diagnosis, or they don't have access to treatments to keep the disease under control. These gaps translate into avoidable complications, higher costs, and this translates also in lives with disabilities, with limitations. So in this context, from PAHO, we are promoting this initiative, Better Care for NCDs, whose aim is to strengthen primary health care as the entry point to comprehensive health systems, effective systems, and based on the person. Our objective is very clear. Every person, no matter where they live, no matter their socioeconomic conditions, the objective for us is for these people to receive a correct diagnosis and a correct treatment. The regional collaboration and the exchange of experiences, of successful experiences, is key or are key. Here, we need to address good practices that are shared in this space. Every single experience that we're going to share today is a success, not only for the country that implemented this good practice, but it is also an example for the whole region. We can see what we can achieve when we combine collaboration, scientific evidence, work, and political commitment. We're going to be sharing examples from Bermuda, Bolivia, Brazil, and Costa Rica. Very, very interesting experiences. These are just some examples of the 40 good practices that have been approved by PAHO and that are available on our website on good practices in public health, which is a tool that allows the health team from the different countries to learn to seize these tools to implement successful experiences and to adapt them to their context, regional context. I want to highlight that these good practices are not limited to isolated cases. These are examples that are scalable and sustainable examples that can inspire public policies that are more effective and that can strengthen the response capacity of our health systems. Finally, I would like to call on you as health service providers, representatives of governments, of the University of Civil Society. Please do seize this space to learn and to commit yourselves to implement, to scale up these good practices for the benefit of those populations that need them the most. Subdiagnosis, subtreatment, subcontrol of NCDs are not avoidable. If we adopt decisive measures, if we reinforce, if we strengthen primary health, we can guarantee that more people are going to be living with in a healthy way. Thank you very much. Thank you very much, Dr. Hennis, the director of the non-communicable disease of PAHO in Washington, D.C. Thank you for these kind words to launch this session of the webinar on good practices on NCDs, sorry. In this second seminar, we focus on the comprehensive management of non-communicable diseases with an approach on primary healthcare. And we want to welcome once again more than 300 people that have joined this meeting from the whole region. I can read in the chat box all the comments from people from Argentina, Cuba, Dominican Republic, Virgin Islands.
We have this session in 3 different languages, English, Spanish, and Portuguese. Our next speaker will be in Portuguese, so I would encourage you to select the language of your choice using the interpretation button at the bottom of the screen. Bueno, dando seguimiento en la agenda.
To continue with our agenda, we would like to invite Ms. Eliana Pereira dos Santos. She's Regional Advisor on Knowledge Management and Networks, and she's going to give the first presentation that is focused on the prevention aspect. She's going to give us a summary of the PAHO program on good practices. Good morning, everybody. I'm Eliana dos Santos. I'm Regional Advisor for Knowledge Management and Networks, Institutional Memory. I work in Washington, D.C., in the headquarters for the region. It's a pleasure for me, it's a privilege for me. I cannot think of two better ambassadors of this initiative, Silvana, Dr. Hennis, because they have really given a summary of everything I wanted to share with you. So it's really a pleasure for me. We couldn't have started in a better way. As Silvana said, I'm going to speak now in Portuguese. So this
na nossa organização. Por favor, próximo slide. Muito obrigada. Bom, contextualizando o que nós fizemos no
Thank
primeiro.
you. Just giving a bit of background from our first webinar where we had almost 500 people joining us. I'm really thrilled to see that some of you who were with us in webinar 1 are back for seminar 2. In webinar 1, we launched a call for action. We presented the results of a few months long journey, and we spoke about how happy we were to have these good practices that were selected. Just in a nutshell, before I start describing the process of working with the countries and institutions, I'd just like to point out that for our organization, this is a movement that began in 2023 of creating an environment and a platform wherein we could find methodologies, validation processes, and highlighting the importance of good practices for the technical cooperation models that our institution upholds. Good practices for our institutions are defined as initiatives, interventions, solutions, methodologies, or procedures undertaken during the implementation of activities and projects, whether at the regional, sub-regional, and local levels, or even worldwide, global projects that may produce results, that have yielded results, and as Dr. Hennis so aptly mentioned it, that can be adapted and or replicated and shared in different contexts, institutions, countries, territories, or organizations. So this is the context within which we designed this methodology that is made up of a series of questions that will lead to the documentation of that given good practice, lesson learned, or solution that was implemented. This will support organizations in lending its support in turn to local authorities, decision makers, public health professionals and institutions, partners, and communities to increase the visibility of their own experiences and in the regional context, that is the Americas, to foster the added value of PAHO's participation in project development.
Next one. Muchas gracias. Como que é o processo de documentação de uma boa prática?
As regards the process of documenting a best practice, there are a few critical attributes, and they are used to ensure that all of these standards are actually standardized to help us identify and validate these experiences. I'm not going to go into great detail just for time's sake, but as you can see in reference, these are the critical attributes in the PAHO methodology to validate a good practice, whether within the organization itself, whether in received best practices from other contexts. What are these critical attributes? Effectiveness, cost effectiveness, efficiency, and a key aspect when learning from each other's. Sustainability. From the very beginning of our projects, what were the sustainability standards that ensure that the initiative is in fact sustainable? Replicability or adaptability to context, a very important aspect that we all look for is to adapt, but also within the context of innovation. And lastly, participation, the involvement of key counterparts and partners, communities, which are all very important within uh, the idea of technical cooperation. Now, this is our portal. This is the first page. As you can see on screen, there's a QR code. You can take pictures of this QR code, and the QR code leads directly to our platform. It is available in 3 languages, English, Spanish, and Portuguese. And the descriptive and there's also a document that is available in French. So these are the 4 official languages in our organization, and they're represented therein. Now, within the context of this important work we did with the non-transmissible diseases and health diseases, the period of work was started in January this year, and we waited very enthusiastically up to 21 March, and that was when we started to identify, document the best practices that were received. In this first point in time, governmental authorities were invited, national government authorities and intergovernmental organizations were invited. They were asked to identify, document, and disseminate their experiences in the NCDs contracts in the region of the Americas. As a result of the call, we obtained an overall number of 83 best practices proposals from 17 countries within our region. 212 users were registered for their best practices. From these 212 within the allotted time frame, we obtained the 83 best practices proposals that were received, and as a result, 40 best practices were approved. You can see some numbers on screen. 21 practices were analyzed, but since they fell outside the context of the invited institutions for this first moment in time, we held on to them for a little longer. So for the second stage, where we will increase the number of institutions that may submit best practices, at this point in time, these 21 proposals will be brought into the fold again and reanalyzed. We're really happy with the result of obtaining 40 approved best practices that represent 11 countries, 11 member states of our important region of the Americas. Next slide. And just to wrap up, what we have on screen is the QR code and the links. So I can see our colleagues have also put them up in the chat box. These specific links are there for these best practices. So read them, get acquainted with them, and also, please keep on contributing, sending us your best practices, because obviously each and every one we get is analyzed, of course, but it is so important to have them and make the difference together. So I'd like to wrap up my words once again, thanking the NMH Payroll Department, specifically Silvana Lucena, Luis Fernando Arancha, to the review committee, including Vanessa Garcia and Roberta Cacheta, who really gave us a lot of support. And once again, my consultant Isabella, who was not able to attend today, but she was absolutely key. And I always feel the need to say this because this is good practices and speak about the importance of work done in community and in tandem.
Excellent. Thank you very much, Eliana, for this collaboration. You have presented a very good summary of this good practices platform. Congratulations to 40 good practices that were chosen for this part of the program through a very rigorous methodology, selection methodology. Today, we're going to learn about some of these good practices focused on the comprehensive management of non-communicable diseases. But before this, we want to give you a little bit of context of this non-communicable disease topic and the clinical management in primary healthcare to present the initiative of the PAHO for better care of non-communicable diseases. Mr. Garcia, thank you for this initiative. Good morning, everybody. Good morning, Silvana. Thank you very much for this introduction. This is a very motivating space. We are going to be listening about the good practices from different countries that we accompany with our technical cooperation. Next slide, please. I would like to share with you, based on the relevance of NCDs, cardiovascular diseases, cancer, risk factors, we acknowledge all the work that is carried out in our country, these efforts to identify best practices. Since 2023, the director have launched a call to strengthen the capacity of primary health in the management, in a better management of NCDs as a priority of our technical cooperation. This is a priority focus on the prevention, diagnosis, treatment, and comprehensive care from the key role of primary health care. The objective is to move forward in the efforts to strengthen primary health care and to strengthen the agenda for this comprehensive management of NCDs. We have therefore developed what I want to share with you. I invite you to visit all, to take a look to all the technical cooperation resources EPAHO made available to you. We have a lot of trainings. We have different tools regarding indicators, visualizations, dashboards on the current status of the comprehensive management, on the control capacity regarding clinical history, telemedicine, everything through our technical cooperation. And what is very important is to improve the access to medications, to equipment that are needed for the management of NCDs. We need to take into account that we have a successful model, which is the one related to the cardiovascular risk, known as the HEART model. It's a multi-component model based on primary health with a special focus on health care for the most predominant diseases. It's a very successful model and it's a scalable model. The objective is for you to integrate these resources, and all of you can this way achieve a better model to move forward regarding this agenda. Next slide, please. Dr. Hennis talked about this. We are talking about cardiovascular diseases. Many countries have already committed themselves to this HEART model. We have diabetes and obesity management, cancer detection screening. We have chronic respiratory diseases, risk factors. Next slide, please. The HEART framework is a model, a framework for those who don't know it. Pay attention to the good practices part, but it is a model, a multi-component integration model from where we address the training of the teams. We have the integration of new technologies for a better decision-making, clinical decision-making based on available evidence with a continuous monitoring of the impact of the whole process. I'm not going I would like to seize this opportunity to invite you to take a look to our initiative space. You will have access to all the resources, the dashboard with indicators, visualizations to describe capacity and monitor progress, the portfolio of medicines and technologies available from our technical cooperation. And of course, you're going to have access to key publications as well. Next slide, please. So regarding the training itinerary, where we host all the resources, virtual resources, we have more than 20 virtual courses based on competencies or skill for clinical monitoring, for managing public health programs, data monitoring competencies. They are all available in French, English, Portuguese, and they are free. We also have webinars such as the one we are having today, live webinars, and we have the recordings of the webinars as well. We have an increasing offer of products related to improving the skills of primary health teams from an interdisciplinary point of view. And to finish up, next slide, please. Here you have a screenshot of what you can find within the dashboard of this initiative. You have the epidemiological context. Here you have the diagnosis, treatment, control of the diseases, response capacity, and maturity of primary health care. Please do go and take a look to this dashboard. It is available in the 3 languages I mentioned. And I would also like to say that here we have the access to medicine, medications, technologies with this specific approach. So hopefully we'll be able to move forward towards the acceleration of this improvement in primary health care. In the last few seconds that I have left, I want to tell you, we have more than 10,000 primary care centers in the region that are working already with this multi-component heart model, with a projection to increase in the next months. It is not only about working on the implementation of this model, but it is about the quality of the implementation. So in this regard, you have our support. Thank you very much. Thank you very much, Jonas. Thank you for presenting the initiative of PAHO for a better care of NCDs. As Jonas said, we invite you to take a look to the website. You have the links on the chat box. You'll be able to find all the tools that are available regarding this initiative. We give the floor now to the presentation of good practices. It was not easy to choose out of the whole 40 good practices. We chose a little group of these practices, good practices. We have here a combination of regions, of topics. We're going to start
with Bermuda. Bermuda has an excellent program developed to prioritize accessible healthcare for hypertension management to achieve universal health coverage. And after submitting the good practice, they were selected based on a very rigorous methodology. So today, Brittany Darko, a community health nursing coordinator from the Ministry of Health of Bermuda, is going to present the case and talk about this good practice. So over to you, Brittany.
Thank you very much. Thank you, everybody. I just want to say good afternoon or good morning, wherever you are, and want to express my gratitude on behalf of our minister, our CMO, Dr. Ramroop, and our senior medical officer, who's just relocated here from Guyana, Dr. Nail Uthman, and our technical advisor, Dr. Patrice Lawrence. I want to express my gratitude and we are excited and we were very happy that we were selected out of these 40 to present this good practice. So thank you very much.
Great, thank you.
So our good practice report was done, the title was Prioritizing Accessible Healthcare for Hypertension Management to Achieve Universal Health Coverage in Bermuda. And that's something that we don't have yet, but it started in 2021. So the public health problem in Bermuda obviously is there is an overall increasing morbidity and mortality rates associated with cardiovascular diseases here in Bermuda. We have large gaps in healthcare access with an estimated 12% without health insurance and a further 23% who are uninsured or underinsured. And that actually refers to those who may have insurance that they would not, it doesn't allow them to afford co-payments such as prescription refills or follow-up preventative appointments. So those are the numbers in a population of about 65,000. So the government of Bermuda recognizes that implementing universal health coverage can benefit both the society and the economy by achieving this long-term cost savings through preventative care and early intervention, and ensuring access to affordable, high-quality healthcare services for all residents. And through reducing hospitalizations, emergency treatment, and treatment of complications, you improve the health population and productivity. Individuals without insurance will be billed directly if they go to the hospital, and there's no cath lab, there's no access to specialist vascular surgeons, so people will be required to have a comprehensive insurance or the ability to pay for these air ambulances. If not, they won't be able to either go or pay for it. I'll have the next slide. So the vision for universal health coverage in Bermuda is just to ensure that everyone has equitable access to the core health services without experiencing financial hardship. So our planning and implementation of the universal health coverage began in 2021. And as part of these efforts, the clinical services for patients with non-communicable diseases were offered and scaled up in the island's only public health primary health care facility, and that's Department of Health, Hamilton Health Center that you see pictured there. Thank you. Our objectives were to improve hypertension and diabetes management. So we want to enhance the blood pressure control and reduce cardiovascular complications among those uninsured and underinsured, and eventually helping those with insurance. We want to ensure equitable access to care, to provide a free standardized treatment and medications to eliminate those financial barriers to the vulnerable populations. And we want to strengthen the health system capacity with PAHO's Hearts in America's module and framework to provide that standardized management protocols and build a better healthcare provider capacity and implement the best practices. We also want to promote population health impact and use the evidence-based interventions to improve that cardiovascular outcomes and ultimately reduce the morbidity and premature mortality in the general population in Bermuda. So our approach to intervention was, first, we launched the hypertension and diabetic clinic to serve the uninsured and underinsured patients free of cost. Now, this step improved access for high-risk populations, and it's basically set a foundation for early detection, consistent management, and the prevention of complications from diabetes and hypertension. Our service expansion in 2023, so we expanded services to address the uncontrolled blood pressure and integrate a risk-based approach. We collaborated with PAHO and WHO to implement the Hearts in America's initiative, and we introduced the standardized clinical guidelines and pharmacological treatment protocols for hypertension management through a clinical care pathway. This strengthened the clinic's alignment with international best practices and ensured consistent care, better patient outcomes, and a replicable model for the chronic disease management. As we continue with equitable access to medications in 2023, we secured and distributed antihypertensive medications free of cost. And as you can see, the chart is a little bit small, but we have amlodipine 5. I tried to give you a picture of what it looks like with someone on the first part of the algorithm of the standardized care, and it costs with amlodipine 5 and telmisartan 40, it's costing around $170 per year for just one person. If they went up a scale and were on 10 and 80, it's $126. It's cheaper. However, one hospital admission to the emergency department, say for a stroke, a heart attack, or a hypertensive urgency, is going to cost the patient around $850. That's just one visit. That's with no labs or CT scans attached to it. So you can see that the cost here is just very large. We, sorry, can go back. We ensure that the medications are being dispensed here at the Hamilton Health Center at the point of care, and that is within compliance with our Pharmacy and Poisons Act, ensuring that it's safe and legally authorized distribution. We ensure that there is a reliable supply chain aligned with the standardized treatment protocol and through nurse inventory and updates on expired medications. And we implemented the ongoing monitoring to track improvement in blood pressure control rates and treatment adherence. Thank you. So here you see the line or the list as we did a phased approach with our main actions of the good practice. So we did the 2021, pre-implementation phase where we conducted health promotion activities. We used word of mouth to encourage patients to come out and check out the clinic. As we went through to 2022, we sensitized healthcare practitioners. We did the HEARTS rollout. They were invited to some of the presentations. We collected baseline data, and we did a situation analysis. As we went down to 2023, we did attend a HEARTS workshop in St. Lucia, as you can see with our CMO and our epidemiologist there on the right-hand side. And then after that, we established procedures and processes for hypertension care. We picked an algorithm that we knew that we could stick to, and then we formally launched the HEARTS program at the Department of Health, Hamilton Health Center. And we just went through and tried to optimize treatment protocols through the policy and a team-based care approach. Coming on to 2024, we tried to enhance monitoring indicators like strengthening the data collection and monitoring of hypertensive patients. We expanded our Excel-based registry with the help of our advisor, Dr. Patrice Lawrence at the facility. And then we slowly introduced DHSI2 to improve the surveillance reporting and the data monitoring. As we go on down to July to December, we tried to improve these strategies and focused on increasing the patient attendance with a target of about 200, bearing in mind that our clinic at the Department of Health for adults was only one day. So 200 patients with a clinic that's operating one full day is quite a lot. So we worked towards better blood pressure control, aiming for at least a target of 80%. And we tested these interventions to enhance follow-up and continuity of care, ensuring that the patients remain engaged. One of the things that we did in this cycle here from January to December 2025 is that we incorporated a booking system. We used 10 to 8 to send text messages to our clients. We had the admin call them the day before to avoid missed appointments and to increase that appointment time. We also offered flexible scheduling and walk-in clinics. We have standardized care plans that and patient-held records to accommodate follow-up. We did patient education and engagement in group sessions in the waiting room while people waited for the doctor to see them. And we also bought a lot of educational tools so that they can visually see the effects of hypertension damage. So the results as of December 2024, our clinic growth and patient engagement. We initially had 120, we had some more clients enrolled, but we had lost them to follow up. So in December, we started fresh and we had 110 clients enrolled. The clinic, initially designed for uninsured and underinsured, became attractive to the insured patients due to the successful outcomes and the team-based care that we provided. We had a consistent influx of new patients with growth across all reporting periods, 6, 12, 18, and 24 months. Our blood pressure control rates, control outcomes were 62% of the patients achieved blood pressure control of less than 140/90 by December 2024. And this is really an improvement from the 25% at the very beginning. The number of clients that in the registry that had a blood pressure reading within 6 months was still under target, but we were still progressing. The new versus returning clients, we had a high proportion of new clients among the total registrations at each reporting period, and at the 6-month post-implementation, 81%, and at the 24 months post-implementation, we had 26%. That was actually due to staff turnover. We had a lot of the nurses transitioning out, and then we had some challenges with our physician. So we had reduced clinic days and times, and that was just more of a challenging time. And our point number 4 is that 1/3 of our new clients presented with a controlled blood pressure, and that highlights the clinic's role in achieving improvements post-enrollment. So as we continue, 60%, so 64 out of the 107 clients enrolled were on the standardized treatment algorithm, and adherence to the protocol improved over a successive phase, rising from 62% to 74%. So one of the biggest impacts is that the health center has grown into a model chronic disease clinic, and it's showcasing really, really big success in hypertension and hypertension management. We've expanded patient reach by engaging to a larger proportion of the hypertension population. We've achieved more than double the blood pressure control rates, which demonstrates the effectiveness of the standardized team-based care. And that highlights the value of structured, free, and collaborative care in improving patient outcomes. And that provides a more replicable model for other clinics. One of the other things that I would note with the key impact is that the team dynamics is really foundation for us for success. So strong team culture was critical for a smooth and sustainable implementation of HARDS. Success depended on the staff being open to feedback, organized, and adaptable. Early attention to team dynamics determined whether the implementation faced barriers or progressed efficiently. Collaboration and flexibility created a foundation for program growth, long-term sustainability, and consistent adherence to treatment protocols. We proactively try to address resistance and foster teamwork, ensuring that the staff engagement directly supported better patient outcomes. And again, this is in alignment with Bermuda's health strategy for providing access to health coverage and providing building better, greater partnerships and collaborative working. So some factors that make it replicable or scalable. The regional alignment and best practices. So Bermuda's HARDS program aligns with the broader HARDS initiative, America's initiative, leveraging the standardized WHO recognized hypertension treatment algorithms. And by adapting these protocols in Bermuda's context, considering the local health system, capacity and population needs, the program reinforces the best practice while maintaining the regional consistency. Ease of replication, Bermuda's protocol is straightforward, adaptable, and it emphasizes capacity building and healthcare worker training. A critical factor enhancing replicability was attention to, like I said, team dynamics. And cost-effective medication. So we address some of the high combination drug challenges with the Twinstar, amlodipine, and telmisartan by just procuring more affordable single-dose equivalents. We had a clear medication selection criteria and guidance for flexible adaptation when the dual combination wasn't affordable to us. As I said previously, it's about $170 to have one person on the protocol, and you can add, it would end up going up to $200 if we gave them a blood pressure machine. So we have very, very strong backing from our Ministry of Health, who facilitates procurement, free distribution, and integration into the national health priorities. Some of our successes, like I said, a strong team and work culture made HEART's implementation very smooth and sustainable. The team-based care, we have distribution of staff responsibilities within the nursing team, and we work in shared spaces. We have collaboration with our social workers who are just on the hall. Our nutritionists are right next to our office, and we have collaborated with the Pharmacy Association of Bermuda. Last year, I presented the HEART framework to Bermuda Pharmaceutical Association, and this directly aligns with the team-based care. And we intend to continue to build up this relationship with the pharmacies, taking the accurate blood pressure measurement course, and patients can attend pharmacies to get their blood pressure checked, utilize their books, get feedback provided, and also just report the results to the clinic. So the pharmacists can also provide blood pressure education, i.e. taking how to take their blood pressure, and also hypertension control. We also had successes with empowerment, patient empowerment. So we increased access to equipment and essential medications, and we made care practical and accessible to them. We had pamphlets and visual educational modules. We had group teaching sessions in the waiting room to reduce stigma and normalize learning and promote self-management. This too aligns with the HEART's module for access to essential medicines and technologies. And we provide all of the essential list of technologies stated in the HEART's module. I just have here some of the things that we have developed, the tools that we have, our HEART's banner, working with a social worker. We have these big posters here in our clinics to ensure that every nurse gives the standardized approach to the patients, and they go through the 8 steps while taking the blood pressure. It's all over our clinic, it's in every room. And I just have a picture here on the left of our admin with all the paper charts. This is a willingness to work as a team, to go through paper charts over and over and over. It can be quite tedious, so we all work together, and it produces a very, very warm and helpful work culture. We also have our community garden, which we wanted to not just tell patients to eat well, but we wanted to show that by doing a garden. And I just have some pictures here of the bok choy and the lettuce that we grew. We had about 100 or about 75 sweet potatoes that we gave out to staff at Department of Health. And it's just an initiative that I wanted to do over the last 2 years, is to promote wellness within ourselves first, so that we can not just say, do what we say, but do what we do as well. The work that we have in progress, or in other words, the challenges, are the social determinants of health. So Bermuda is extremely expensive. There's a high cost of living. There's a lot of food insecurity. There's limited transportation options. A bus fare is $5 each way, depending on where you live. There's other barriers to accessing financial assistance, and patients missing follow-ups because no work equals no money. And these environmental and socioeconomic factors do influence patient engagement and outcomes. There's another challenge that we have, and it's readiness for change. There's inconsistent follow-up with the nutrition services, ambivalence towards medication despite its availability. There's hesitancy there, and health fatalism. Like, some patients feel like the outcomes are predetermined, and it reduces their motivational lifestyle changes and treatment adherence. Patient attitudes and engagement affect the implementation success, I believe. In addition to these work in progress, we're trying to have an expanded clinic, so to go from 1.5 days to 5 full days a week, so we can scale up HEART's. And we are working towards a more electronic system. Hopefully we will get that one day. Some of our key stakeholders and alliances are the Bermuda government, the Ministry of Health, who leads in policy development, funding, and the coordination of universal health coverage. Bermuda Health Council, who oversees regulation, our strategy alignment, and ensures accountability and system performance, and the Department of Health, who directly supports the implementation of the community health programs, and of course, our international partners, PAHO and WHO, who provide that technical guidance, training, funding, and the global best practices through the HEARTS program in the Americas. So we thank you, PAHO. I just have a picture here of us. We did our Hearts video that was featured some time ago, and these are the two people that were featured in the video that gave their consent. And Paul, who says that, you know, he comes faithfully and he believes that the results are good for him. And another uninsured lady who's Marika, who used to previously work for government. She lost her job. So now she's uninsured. She has 4 kids and she's glad she has the ability to come somewhere where she can get everything she needs. Thank you very much. I hope this presentation was helpful to you. And again, thank you, PAHO, for choosing Bermuda to be featured here today, this afternoon. Thank you.
Thank you very much, Brittany Darko from Bermuda Ministry of Health, showcasing this good practice in NCDs on hypertension management. And I was part of the selection committee in reviewing all of the cases we received. And I think I could comment that one of the things that struck us in the committee with this example was how you focused on the uninsured or underinsured population. You were aiming for equitable access for primary care. You were reducing some of the barriers that we know exist in primary care. That is the cost of services, the cost of medication. So really tackling some of those big barriers, as well as the standardized treatment protocols, the patient education and follow-up. And then, of course, the extraordinary results seen as a result of implementing the initiative with 62% hypertension control, starting from 25% control rate. So congratulations again, Brittany, to you, to the entire team for really leading and showcasing. And we hope that this case has been a stimulation and a motivation for other countries to do something similar. So thank you again, Brittany.
Thank you. Thank you all.
Great. Así que seguimos en el programa y vamos al
Let's
segundo.
continue with our program for today. We have the second best practice case from Bolivia about the evaluation of the essential conditions for the attention of non-transmittable diseases among indigenous communities. In order to present this case, we have Dr. Mary Salazar, responsible of health from Santa Cruz de la Sierra, Bolivia, along with our colleague from PAHO, Mr. Ojeda, as an assessor of non-transmittable diseases or non-communicable diseases. The floor is yours. Thank you very much, Dr. Silvana. Can you all hear me? Excellent. So in order to start with this presentation, we wanted, first of all, to thank all of you for this chance to share with you today. And this moment is very much interesting because we can learn from other countries and also share our own experiences from Bolivia. Because last year from the PAHO, we were able to mobilize some resources in order to carry out actions on the primary health attention in Bolivia in a much more integrative and integral way. When we started analyzing which actions we could approach or carry out from non-communicable disease area, we realized that we had the necessity of having information that would allow us to take the best decisions jointly with the local team. And when we went to carry out this intervention, we realized that we were lacking of a tool at regional level that will allow us to have this information in the same way that the local teams will need it. This is why we roll up our sleeves and we started identifying different tools worldwide that will allow us to generate for once and for all something that they will help get this information, not only about the behavior of the non-communicable disease, but how much the health services were prepared in order to respond to this. So in this sense, the first thing that we did is to trying to do actions inside the organization and outside the organization, organizations that were characterized by a joint action. And with the local team, in this sense, we carried out the analysis at level of organization. So we carried out an extraordinary effort from different of our areas in order to identify these tools and the variables that we were about to study at Bolivia level, also at regional level, but also at level of the local teams through the participation of the stakeholders that in daily basis are there, the local governments, the local centers of health, and also universities and community. So it is in this sense that once and for all, we convert all these processes, giving space for the origin of this new tool for the world of non-communicable disease, which is a tool called the tool for essential variables detection. So in order to introduce you to this tool, I would like to invite Dr. Rosemary Salazar, which is inside the Chaco of Bolivia, 850 kilometers away from La Paz, in the autonomous originary Guarani Yambay territory. And she's going to comment us how in Bolivia, not only we do things, but we do very good things about public health. So Dr. Rosemary, the floor is yours. Good morning. I wanted to thank you for your invitation in order to be part of such relevant meeting. I would like to thank Dr. Silvana for invite us, and I want to be very much consistent about the context and the way or the motivation why we intervene with PAHO. I'm responsible of the health of all these territories. So let's talk about Camiri and the autonomous government. I'm going to refer to the region called El Chaco in Bolivia that is facing very huge risks of public health due to the big poverty index and the population dispersion. What do I mean with this? Our communities from one extreme to the other, it will take 15 minutes to reach one place and another community. And when it rains, it is impossible to reach this territory in order to provide health services. Then about the non-communicable disease, cardiovascular diseases are the most common in El Chaco. We know that trypanosoma is what transmits. Here we know it as Inchuca, but in Guarani it's called Timbuco. This is how we know it. Our people, almost 70% of our people speaks Guarani, is the most common language in this area. Also, we have respiratory disease, chronicles, diabetes, the water that we drink, we don't have potable water, drinkable water. We take water from the tap, so our water has lots of salt content. So it's very hard to fight against hypertension due to this because our water is salty. And also we have cancer. This is a place double challenge because the high charge, high load, and the lack of services. And we need to generate evidence in order to accelerate decisions and a proper health management integral for non-communicable diseases in the primary attention. So we carried out this in order with the module of non-communicable disease through the tool of valorization of WHO and PAHO in El Chaco. The main actions and good practices. The creation of the non-communicable disease model has 50 questions on 10 dimensions that are key. The access of medications, diagnosis in the health establishment, attention and clinic follow-up, governance, leadership, financiation, health staff, information system in health, organization of the service provider, installation of primary service hubs. We carried out an interprogrammatic and intersectorial work, training 45 local professionals, not only doctors, also technicians, and physicians from different areas. Because these were a recycling of professionals. We intervene different health services. What was our methodologies? Our DCD tools were applied in different way with the review of the registration, visits, information of the operations, and this information was translated in digital formats. However, in some communities, we don't have internet service or we don't have a great connection as I have now, right? I found a place with a good sign, but in order to this work to be trustable, we carried out everything in writing in order to be able to reach these in those places where there is no internet and to gather the information. We carried out this type of radar type of models in order to visualize the gaps and the strengths integrally. The first and second level of attention also was assessed with identifying critical gaps with the generation of evidence in order to plan actions on immediate intervention. The results were that the data are insufficient against the high load of non-transmittable disease in the region. This situation is critical if we consider the extreme poverty and the geographical conditions because our communities are very much far apart. So unfortunately, we have some health infrastructure that is made by mud, just rocks and mud. So we don't have infrastructure, and this is our reality. This is what we are experiencing in Bolivia.
Sistemas de información con fortaleza en pruebas básicas, medicamentos esenciales, continuidad
essential medication, continuity of the care. Committee stood out in basic equipment and clinical follow-up. Well, Gaiki did some local planning and availability of specialized personnel. All our patients that have complicated status, we have to send them to committee. This is our area of transparency. We have the resolution capacity, but unfortunately, we don't have the equipment, the infrastructure we need. Next slide, please. So factors that make it replicable or scalable. The module is adaptable to other contexts with similar needs with both national and regional application, alignment with regional strategies within a tool that is already established, that has been validated and applied in many countries. Use of existing resources, its implementation does not incur any additional costs as it uses the same economic and human resources, ensuring a high probability of long-term sustainability. Next, key actors and partnerships. National team, NMH national team, and NMH regional team from PAHO. Technical support for adaptation and implementation of the tool, as well as for the analysis of results. The NCD department and the Department of Evaluation of PAHO, we also have the participation of local authorities, Sede Santa Cruz, Camiri Municipal Government, Guarani, Queremba, Yambae Indigenous Autonomous Government, Health Networks, Tecovecatu School of Public Health. This is a technical school and the social structure of the Chaco region. The social structure of Chaco here is key for us because they monitor, they're the ones that are going to tell us if there is any emergency, any important case in a community. Sometimes the doctor is not aware of this, but they come, they talk to the doctor, and this way the doctor is aware of what is going on within the community. So this is very important for us. Next, please. These are the tools that we manage, with which we work. We give priority, we take care of our patients, VC tool with the NCD module made it possible to reveal invisible gaps in primary care in the Bolivian Chaco. This is just some pictures for you to see. Dr. Ojeda, Dr. Noelia, thank you very much for training me, for helping me to share what is going on in Bolivia, in the Bolivian Chaco. Thank you very much, Dr. Rosemary, Dr. Hector, for this experience applying this essential conditional tool for NCDs. This was chosen as a good practice because of the implication of all the main actors at a local level, and also because of how the needs were assessed, which is the first part of reinforcing, of strengthening public health or health services, identifying the gaps, the needs. And we have seen that with these results, with the results of this assessment, there are three key areas: financing, human resources, and inputs, such as medication, diagnosis, inputs. These are gaps that are present in the majority of our regions. Congratulations for this implementation, and hopefully with these results, you'll be able to strengthen your services. Thank you very much again. Thank you very much in Guarani. Thank you once again. Next, we're going to Brazil, where they implemented a project to prevent cervical cancer. Ultra es Vida is the name of the project. It is a project that uses a new technology to strengthen the care for this cervical care. I invite Dr. Elina of the Pernambuco Health Secretariat to present their experience. Thank you. Good afternoon, everybody. I'm going to speak in Portuguese. We have the translation.
I would like to thank you for the opportunity. We're very glad to have the opportunity to present our best practices project. I represent the Ministry of Health, and I will be speaking about the partnership the Brazilian Ministry of Health has established with the State Secretariat of Pernambuco and all of the partners in this pilot project, which is designed to qualify the care of uterine cancer in Pernambuco through a perspective that intends to also support the rest of the country later on. So just to give you a bit of background, why did we start off this project in the state of Pernambuco? In Brazil, the uterine cancer is the third most prevalent in women. That is 6.68 for every 100,000 women. In Brazil, we have a coverage model that refers to tracking, opportunistic tracking with a low tracking coverage, and challenges throughout the whole care accessibility line. We started off in Pernambuco because the State Department, whose manager in the state, recognized this critical situation with a high prevalence in the state of Pernambuco, 20.84 per 100,000 women. That is above the national average, and with a high mortality rate over the mortality rate for Brazil as a whole. This project began in Pernambuco in 2019 with the support from PayHo through a technical cooperation project to qualify this attention model that started off with primary care tracking, then moved on to third line tracking, and all of the ensuing care. Now, working on the partnership with the OPS, we designed a pilot project for cervical cancer or uterine cancer in Brazil based on organized tracking. HPV molecular test offers, which had previously was not offered in Brazil. And since 2024, this test has been brought on board in Brazil and is widely used now by the Ministry of Health. And moving on a little, in Brazil, the federal government asked us to develop a national molecular test. We wanted Brazil to work according to its continental size, and producing a test using national technology ensured sustainability of this technology in tracking cervical or uterine cancer in women. Another aspect of this process is increasing HPV vaccination coverage with several different strategies, especially awareness raising in schools to help us increase vaccine coverage. Now, what is our main goal? As I said before, this is a pilot project in the state of Pernambuco using organized tracking devices so we could transition this technology. Now, in Brazil, we're currently transitioning in terms of technology. We used the in situ pathological test for tracking, and we are currently transitioned towards the use of the molecular test for tracking purposes. And now this transition kicked off in the state of Pernambuco with this pilot project. We're also trying to increase the strategies for HPV vaccination coverage. We want to build a corpus of evidence so this project can be implemented in all states in Brazil. Brazil has a total of 27 states, and so the idea of our project is to garner elements so the project can be replicated elsewhere in our country. What are the main practices and activities in our projects? Firstly, implementation of the pilot project itself. Start working with the molecular test. This is the first time in Brazil. We had a prior strategy of developing this molecular test in Brazil, but the effect of that prior strategy was simply having the companies that were already in the market, having them decrease their price thresholds within the Brazilian market. Another activity is having campaigns in schools because we wanted to increase HPV vaccination coverage. We have a partnership with civil society organizations. One of them is called Mulheres do Brasil, and they have helped us get closer to the population in schools and in communities, both for parents and kids and teachers. It is important to raise awareness regarding the importance of HPV vaccination in prevention of uterine or cervical cancer. And lastly, the educational activities. When we shift towards organized tracking, we want to make sure that this woman has access to treatment of the lesions that are precursors to cervical cancer. And we want this process to kick off diagnostic investigation and the treatment of the cancer itself. Now, in terms of primary attention and moving on to secondary attention, sometimes takes too long for these women, and sometimes the illness progresses to more advanced stages. So our project also aims at working closely with this woman to ensure that she does not waste time, both in terms of having their diagnostics and also in terms of starting treatment as quickly as possible. So what have been our results thus far? The project began in 2023. We've already run over 20,000 more, actually 20,590 molecular tests in 24 different municipalities. These are the numbers till February 2025, which was when we started working with the best practices. And right now we have reached the threshold of over 35,000 tests that have been run. In terms of our activities in schools, we've had 16,000 vaccines that were applied to people, to a public from these schools. The project has reached 2,536 schools in all of the 24 municipalities that make up the state of Pernambuco, and over 10,000 vaccinal doses have reached the population, have been applied, and we're really excited to have met our goals in our strategy for the elimination of cervical cancer as designed by the WHO. And this is vaccination of children and kids in Brazil is sometimes a challenge. Now, this vaccine is offered free of charge by the federal government. However, we have found challenges in terms of barriers to vaccinations because there are issues that have to do with parents denying vaccination, the anti-vax movement, and therefore, the awareness raising activities have been absolutely key for these parents to understand the importance of the vaccine. And Brazil, we work with a single dose vaccine against HPV. We also had a series of activities that reinforce the importance of vaccination for the schools. And also, as I said, I'm going to put up a picture of other activities that we have as regards capacity buildings for community agents, for community healthcare agents in Brazil. At the bottom over here, as you can see, so we work with capacity building and awareness raising for the target populations, that is women, children in case of vaccinations, children and teenagers, but we also have a host of activities that have to do with capacity building of the team itself that makes up the family treatment units. So what are the factors what are the factors that contribute towards sustainability for us? The Ministry of Health normally generates a large number of normative measures. We have already issued several that have to do with cervical cancers. We've also issued manuals that help managers. There have been several that have been published, which are evidence-based within our project. Educational materials for the population and especially for the target population for cervical cancer tracking. Also capacity building materials for healthcare professionals in primary healthcare and in the change of the tracking approach from opportunistic to organized tracking. We've also worked on capacity building for this change itself, and also capacity building in terms of awareness raising for women when they get to the healthcare facility. And in terms of sustainability, we have financial support from the ministry in terms of health, in terms of supplying the molecular tests, and in reorganizing our primary health care management and healthcare monitoring teams. When we're thinking about a change such as this in terms of cervical cancer, we also have to consider issues regarding labs, lab networks, and we're going to be speaking about the partnerships we've established a bit further on, and our partners have lent their support to the state of Pernambuco, and we're going to lend their support to other states of the Brazilian Union who are coming on board. This month, we're going to start replicating the strategies from Pernambuco in another 12 states in Brazil. It is quite a challenge. And for the state of Pernambuco, where we have had the opportunity of implementing everything that we mentioned before, we feel very thankful to the team that implemented all of these changes in Pernambuco. They have been fantastic in facing these challenges. Another partners of ours is Fiocruz, who is also under the Ministry of Health. They were the ones who developed the new technology for molecular testing and have also lent us their unwavering support, both in terms of developing technological innovations and for training and monitoring for labs in the implementation of the molecular testing devices. In terms of the key actors and partnerships, as I said before, the state of Pernambuco Health Department, without their support, we would have been able to achieve absolutely nothing. Their dedication, their hard work were incredible. We owe them a lot. The Ministry of Health, I represent the federal Department of Coordination. Also as partners, the National Cancer Institute and the General Coordination for Preventions and Protection within the primary healthcare attention sphere. So we have partnerships within the Ministry of Health and with other partners. Of course, PAHO, we'd like to thank their department for non-transmissible diseases and healthcare, the Brazilian team, the team from Washington who worked so hard with us on this project and have always lent us their unconditional help, and we really thank them for their partnership. And just a bit more on what the WHO has done in terms of support for us, developing the test, the clinical validation of the test has been supported by the OPS. It is a real joy to share with other countries what we've attained in our project. This project is ongoing. It's not wrapped up yet. Every single day we see a larger women being tested, a larger number of kids being vaccinated, and a larger number of women being treated for cervical cancer precursive lesions in Brazil. We also have partnerships with non-governmental institutions that have lent us their support in communication with the population, with school organizations, school moms organizations. Without their support, we wouldn't have done as much. So I really thank you for the opportunity, and let's move on together. Thank you very much. These are pictures taken within our project in the capacity raising in the workshops, monitoring workshops, and our work throughout the world in which we spoke about our project in different
Thank you
places.
very much,
Thank
Aline.
you.
Congratulations for this project. This is reaching thousands of women to prevent cervical cancer with new technology made in Brazil. It has been approved, validated externally. So congratulations for developing this technology, for implementing it within the program, and for the commitment to the elimination of cervical cancer. Thank you very much once again, and congratulations. Thank you. Next, we are going to Central America, to Costa Rica, where we have good practices regarding comprehensive management of NCDs in the workplace. I invite Dr. Tony Bennett Murray from the Limon Health Authority.
Doctora Tony, ¿estás por ahí?
Dr. Tony, yes, can you see my screen?
Sí, adelante.
Yes, go ahead, please. Can you see the presentation?
Ahora sí.
Yes, we
Puedes
can.
ponerlo en forma de
Maybe you
presentación.
can select the presentation option.
Adelante.
Go ahead, please.
O si prefieres, nosotros podemos
Or
manejar la
we can
presentación.
manage the presentation if you prefer. Yes,
Ok,
please.
gracias.
Thank you.
Ok, está ahí. Adelante.
Okay, we're ready. Go ahead, please. So, I represent the Ministry of Health in Costa Rica to present the comprehensive management of diabetes, hypertension, blood tension, obesity, and mental health. We are leading this section from Limon Health Authority. How does this begin? No, relating the diabetes topic. In 2017, in Limon Province, we carry out a diagnosis of patients from the Social Security. So it was diagnosis of patients with diabetes in 6 cantons. Oh, with diabetic people, we register 17,103 users. 25% corresponded to the Limon Canton. What is the challenge here? That we need to reduce the impact of comorbidities and develop network-based treatments. What is the justification of the work we carry out? We identified demographic and epidemiological changes at a national level, and we identified that NCDs are the leading cause of death, morbidity, and disability. In 2019, they accounted for almost 80.73% of deaths for NCDs in 2018. In the canton, in Limon Canton, the most notable are hypertension, diabetes mellitus, obesity, and chronic respiratory diseases. We have, in this context, changes in behavior and lifestyle habits, uncontrolled patients with poor adherence to treatments. So the disease is more difficult to manage. We also face health problems associated with social, economic, cultural conditions, as well as living conditions and belief systems, which makes it difficult for patients to continue the treatment. The demand for health services at level 1 and at level 2 care, in which we identify that there can be an inadequate follow-up, staff shortages, overcrowding in the services, among other issues. Next, please. Regarding the context, regarding the political or institutional framework, in Costa Rica, we have the ENCHO strategy from 2013 to 2021. And this is a new update for 2022-2030. We also have an action plan for NCDs for 2022-2025. This is based on an agreement of the CCSS Board of Directors, in which the Huetara Declaration is designated as a demonstration area for the development of the project, and it is agreed to choose the Limon Canton for this project. Which is the objective and the approach of this project? An NCD approach with a network focus, in which we have an interinstitutional and intersectoral integration for comprehensive intervention. The main objective is the reduction in the incidence rate of NCDs in the canton, and also to generate a behavioral change so that the population can become and take ownership of their own process of change and the adoption of healthy lifestyle adherence to treatment. We work in the workplace for this project. We have a multi-sectoral action. Of course, this project is carried out with different institutions of the canton, public institutions, private institutions. We have institutions from the health, education, energy, communication sector, justice sector, airport, ports, environment sector. This initiative, as I said, is for the Limon Canton, and this canton is made up of 4 districts in which we carry out the strategy.
Currently, for our strategies, we have 27 institutions as part of this network. Out of these 17 institutions, 12 has been awarded, others in phase of execution of the work, and 3 are in the process of registration. Next one, please. What is the approach of our intervention? So for the institutions that has been awarded and are carried out their work plans, we are trying to them to adopt the actions that they have established in their plan. As an institution that leads the strategy, we are not we don't give them the following steps. They agree according to on the resources, institutional resources that they have. They can decide what to do. For example, among the institutions that participates, we have the local government, Limon's municipality, and as part of the actions that they carried out, the different offices that are part of this municipality, they can provide information boards, disclosing information for prevention of diseases or in order to promote health in the case of diabetes or hypertension, obesity, and mental health. Also, they have coordinate the organization of walks in order to promote physical activity. They have carried out some workshops about the management of diabetes, how to carry out functional exercise. They have had a roundtable for the people that is diagnosed with diabetes to share their experiences. Also, the regional hospital participates with it, the Hospital Bonifacio Castro, and at the same way, at different levels of their services, they work with the working population, carrying out workshops, talking about obesity, diabetes, risk factors, cancer, and some other issues. And as part of this, to the users that are carrying these types of NCDs, as part of the hospital, they have been awarded with a certification of acknowledgement to those officers in order to make their own commitment in order to improve their health. And as a rectorate area, we are not behind. We also participate as part of this strategy. And what we do is to carry out workshops about issues related with diabetes, health, nutrition. Also, we do screening to the officers. We want to provide to foster physical activity with different hours of training and exercise, like Zumba and others. What are the main actions of our good practice? We have concrete actions. The first one is the disclosing of the strategy for the integrative management of diabetes, hypertension, obesity, and mental health. We carried out coordination and intersectorial linkage between the private and public institutions, so them will be part of our strategies, will sum or add on to our strategy, and providing follow-up we actually follow up with them. We request them to be registered, to present their work plan. We support them and accompany them during the issuing of the plan. And the idea is that as part of the plan, for a period of time that they will determine, they need to generate actions that they will carry it out. Part of these actions, we request also to have two actions that are specific. One is to fulfill or complete a follow-up form with each one of the officers that we are working with in order to monitor the advances in the approach of their NCD. And at the same time, despite of this follow-up, we carried out a screening. What is the screening all about? It is about of carried out coordinations or do coordinations for the health facilities in two scenarios. The ones that they have already a physician, so they can do their coordinations among them in order to provide lab testing, take arterial testing, or samples to the officers, the glycemic or anthropometric measurements as the weight, the size, the abdominal circumference, and other measurements. And once we have that screening ready of all the officers, we leave this information in this registration template in order to have the data that will do follow up after 6 months of 12 months in order to follow the evolution of the officers or officials. We carried out these actions, and after that we have done or they have already finished their work plan and this work plan has been executed, we do the evaluation of these actions through the implementation of a questionnaire. This questionnaire is for the verification of proven of accomplishment of the actions that they have identified
Realizar este proceso de evaluación y que
in
todo
their
esté
plan. After of the evaluation process and after everything it is okay and follows what it's been programmed, we proceed to provide this award. It's an award that we give to the institution due to the great work that they have carried out in order to care for the wellness of their staff, their officers. After that, we do a follow-up process because after the awarding, it doesn't end there. Because in the case of the institutions that has some lack of
Como parte del convencimiento, se realizan visitas a cada una de ellas, conversando con jefaturas responsables de medicina laboral, si existiese en la institución, o representantes de salud ocupacional para hacerles presentación del proyecto y así invitarlos a que estos puedan ser partícipes y se inscriban. Se les da el otorgamiento del galardón en los distintos momentos en que se presente y según los avances de la ejecución de los planes de trabajo que estos tengan. Los galardones que han sido entregados es acorde a las acciones que están ejecutando. Si es en base a diabetes, hipertensión arterial, obesidad y recientemente fue que se incluyó salud mental. Por parte de la red se hace entrega de material educativo digital. Este es compartido vía correo electrónico a todos los representantes de las instituciones y se hace la realización de un evento anual que es el encuentro de instituciones galardonadas. Previamente se hacían reuniones bimensuales con estos actores sociales. Estas reuniones eran presenciales. Sin embargo, estuvimos con el abordaje de COVID-19. Estas reuniones tuvieron que cesar. Luego se retomaron de manera virtual. Sin embargo, identificamos que la práctica no era muy acogida.
So after we identified that this practice weren't that much the favorite one, so this is why we changed this to 1 year meeting. Also, we like to engage patients, at least one patient for each institution, in order to promote the great experience that they had with their approach, and for them also to provide information and feedback. And as I mentioned, the registration template, which is basic in order to provide follow-up the advances of the attentions that the collaborators are having or experiencing. What are the results and the impact that we achieved through this strategy? Well, we have documented 3 successful experiences of institutions. Among these, we have the one for the Integral Attention Service located in El Limon. And then we have the electricity company and the oil refinery. These are institutions that had been awarded. And as part of the successful experiences that they provide to us, they 3 have the common denominator, which are the diabetic patients that during their screening, they have hemoglobin glucosylab levels above 11. And after following the recommendations of the treating physicians, and after the follow-up they have received, and after the good following of the treatment, in these 3 cases, we were able to identify reduction of these glycosylate hemoglobins in values that are under 6. About the lessons learned, we considered that this strategy can be applied at other levels independently of if they have corporate doctors, of occupational doctors, or no doctors. So the ideal is to do this stimulation systematically among all the institutions that are part of this process. We have identified that providing an award and having these considerations has been a great motivation that has kept the amount of participation in these strategies. We've been doing this for 6 years already, since its first implementation. And even if it's true, this is a slow process, each year we have more institutions that are part of this. We also want to continue establishing sustainable follow-up mechanisms in order to monitor the changes that we have generated. We want more participations, more meetings. We had identified that all these institutions are very much willing to continue working with this strategy. But for this, we need to carry out more integration type of activities in order to renew the commitment of the institutions that are participating. And all other, thanks to the activities that we have implemented, we were very brave and good maintaining the motivation up among all the participants. Also, we measure the advances of the execution of the plans. This is done through the evidence that are given through the follow-up evaluations that we carried out, and also into the data registration template. In this way, we can also secure the statistical follow-up of the users, as well as images, photographs, and videos of all the activities that they have organized in order to execute the plans. The initial phase is the result of the convinces process and the commitment process. So for this, it is important to respect the internal functioning of the institutions. Their work plan, as I already said, needs to be adapted to the resources that the organizations have. We don't impose any activity that they have to do. And we consider that this was very vital in order to make our strategy lasting over the years. Then we know that all the institutions already have their own plans that they need to accomplish. So this strategy, it is an additional activity for several for them. However, they are very well committed, and they make this work very effective thanks to this. The replicable or scalable factors, yes, of course, we have identified elements that enables this adoption of the strategy in other contexts. The acceptance, the availability, and the installed capacity of the private and public institutions that are about strategy. the access to the health system and company medication. When we have institutions that they don't have indoor physicians, this is an additional cross because we have both scenarios. So with this, we can refer them to the first level of attention system, so for them to be served. During the elaboration, execution, and follow-up of the work plans of the organizations, this is done along the whole time frame that they have defined for vigency of their plan. About sustainability, the work of the organizations and through the encounters that we had and the experiences that we had, we have taken all these lessons learned as a feedback for all the institutions to be able to be familiarized as we work with the different organizations. And after that knowledge, it's given they can adopt the best practices on their work plan or the length of the actions that they wanted to endeavor. We don't oblige nobody to carry out actions. They need to organize their access according to their availability and resources. Each institution does its own. About technology innovations, we have our award for hypertension, diabetes, obesity, health service, health, mental health. Then we have the intersectorial consultation through our network. We can raise any query up to the second level of attentions in case it's needed or in order to do the follow-up. Also, the award, again, it's been considered as a feedback for us in order to strengthen our network as well. So during our encounters, we had invited specialist doctors that had provide presentations about diabetes and hypertension, management of patients, and pharmacological treatment, and more. I would like to highlight that as part of the institutions that are participating, we have the participation of the Penitentiary Center of El Limon that has something very special because the difference is that they don't work with, we don't work with them with their staff, but we work with them with their inmates. This strategy was very well welcome for this population. They were very grateful and they are working very hard in order to fulfill the strategy. And we are open to any non-conventional institutions as well. As part of the institutions that are part of the program currently, we have institutions from the health sector, the participation of the regional hospital, the rectorate, the Ministry of Health. About education, we have participation of the Technical School of Doctors, Educational Training Centers, and the Atana University. These institutions from the educational center, they don't have in-house doctor on any type of labor health programs. However, every action that they do is in order to prevent health and promote health. About energy telecommunications, we have the participation of the Electric Institution of Costa Rica. This is an institution that has 3 facilities for Limon, and we work simultaneously the 3 main hubs. The Justice Ministry, also the Judiciary branch is participating, the Penitentiary Center, and also the Public Force Delegation. At level of maritime and ports, we have the participation of the biggest ports of the area that are called ADEVA, the Committee of Port Administration and Economy Development for the Atlantic, and the other terminal. About energy and environment, we have the participation of the Verter company that are, these are in charge of the fillings, landfills, and the municipality of Limon. All these institutions are being already awarded because due to their work plans, and about the role of the civil society for the execution of this project. We have access to and materials of several institutions, resources of physical installations inside the institutions, like spaces where to have our workshops or spaces to promote information and so, and technological equipment and other equipment in order to enable the disclosing of information. We don't have financiation, neither domestic or internal, in order to carry out the strategy. All financiation is done with the own resources of the coordination team and evaluation team in charge of the health ministry and the Social Security Savings Bank from Costa Rica. Next one. In this next image, we can see the awarding of the acknowledgement of to the different institutions. We see the awards and some murals that are being displays of information in the different institutions. Then they also have organized activities for mental health and physical activity at the beach. Here we see they have organized a CrossFit event among all the staff. These are representatives of the technical school of Valle La Estrella. Also, they have created spaces in order to share a breakfast or a lunch among them. And also in these spaces, we review the clinical files of the users in order to identify the follow-up that has been done based on their diseases, the coordinations that they had made with the Social Security institution in order to provide the screening of the officers of those institutions that does not have an in-house doctor. And this is another picture of the award, as I mentioned before. And this will be all from my side. Thank you so very much, Dr. Townie, for this great experience share in Limon, in Costa Rica, that was selected as a good practice due to this multi-sectoral approach, the leadership and coordination at local level, at regional level inside the country, and also this approach of these labor environments for the medical attention for non-transmittable, non-communicable disease, the wellness, the promotion of a great health was wonderful. Thank you very much for sharing your excellent experience. And after this, we have reached the end of our seminar. I hope that you will be able to take advantage of all these great experiences and great practices for the attention of non-transmittable disease. Yes, this is not only an acknowledgement of the work that we are implementing in the region, but also it's in order to visualize this and to foster the reply of this experience. All for all of you, all the 40 experiences and great practices are published in our PAHO platform. So you are all invited to review this in much depth on our website. And we're going to continue with this webinar series showcasing the good practices of NCDs. The next one is this program by the end of September with the approach about vigilancy and monitoring of non-communicable disease. So we're going to keep in touch. We're going to spread all the information that you may need during our website and the survey of NCDs. So thank you very much. Thank you to all of you for your participation. Thank you for the presenters to give us part of their time, and especially thank you for the interpreters that are helping us with, or they're helping us to having this information available in 3 languages. Thank you very much to all. Have you all a great day. Goodbye.